Good morning, everyone. Good morning, everyone. Thank you for joining us today and attending our Grand Rounds lecture. Today's lecture is part of the George Vetrovec Cardiology Symposium. It was founded in 2015 on the occasion of Dr. Vetrovec's retirement. And the purpose for it was to have an annual cardiology lecture for the Division of Cardiology. Dr. Vetrovec is one of the pioneers in the evolution of percutaneous coronary interventions. He was the chair for the cardiovascular department for 18 years, was director of the cath lab for 38 years, and associate chairman for medicine for clinical affairs for 23 years. I'm pleased to introduce our speaker today, Dr. Don Abbott. Dr. Abbott is a professor of medicine, associate chief of faculty development and academic advancement in the Division of Cardiology, director of interventional cardiology at the Lifespan Cardiovascular Institute, director of the cardiac cath lab in Rhode Island and the Miriam hospitals. She served as the director of the Interventional Cardiology Fellowship Training between 2009 and 2022. She is a high-volume interventional cardiologist with expertise in complex coronary interventions. Her research interests focus on improving outcomes of patients undergoing coronary, endovascular, and structural interventions, and those with acute coronary syndromes. She has received research grant support from the NIH, the ACC, and industry. She has over 200 peer-reviewed publications. She also served as a deputy editor of the Circulation Cardiovascular Interventions and is on the editorial board of several cardiovascular journals. She is an active in leadership of the National Cardiovascular Societies, including ACC and SCAI. We are grateful to have Dr. Abbott today, and we're grateful for her expertise on this topic and look forward to learning from her. At the end of the lecture, we will leave time for questions. Please submit questions via the chat function in Zoom as they arise during the talk. We are pleased to offer both CME and MOC credit for the Grand Rounds conference series. To claim credit for today's session, text the code shown at the beginning and the end of this presentation to 804-625-4041. For questions or to log into your Cloud CME account, visit vcu.cloud-cme.com or contact Shannon Winston. I will now turn it over to Dr. Abbott.
Good morning, and thank you for the invitation. And it's really an honor to present in the George Vetrovec series, being a luminary and a mentor and a good friend of mine. I'm so happy to come and speak to you all today. I chose the topic of evaluation and management of chronic coronary syndromes in the hopes that we can move beyond thinking of coronary disease as only obstructive atherosclerosis, and my involvement in the ANOCA guidelines and some of the other recent scientific statements led me to put this case-based talk together, which I hope you guys will find interesting. Here's my disclosures there. I'm not talking about any specific products this morning. So we're going to just start by covering in the next 45 minutes a pathophysiology of angina, including macro and microvascular contributions. There'll be 3 case studies that demonstrate the challenges in treating and diagnosing patients with chest pain. And then we're going to talk about ischemia with no obstructive coronary artery disease, the different endotypes, and some of the difficulties with management. We'll talk about obstructive coronary disease, which everyone is quite familiar with, and some recent research I've been doing on anti-anginal therapy, and then have some time to talk. So you all know the background and the scope of the problem, and during one's lifetime, there's at least a 40 to 50% chance someone will suffer chest pain, and many of these individuals will present to an emergency room or to a physician with this complaint. And it's really a diagnostic challenge, and as cardiologists, we may think of this as a routine and have a pretty good sense how to risk stratify people, but it's really stressful for clinicians and emergency physicians to work through these symptoms, which leads to a lot of testing, and a large proportion of patients actually get referred for angiography that end up not having obstructive disease. And some of that can be an underappreciation of some of the different pathophysiologic mechanisms of ischemia. Here is a nice, I love this figure, which really breaks down different mechanisms of ischemia, which everyone knows is really due to a mismatch of coronary artery blood flow, supply and demand. When you have that inadequate cellular availability of ATP, you get myocardial ischemia. The classic description is the atherosclerotic coronary disease, where you have progressive obstructive disease leading to downstream changes in coronary flow, which ultimately lead to ischemia. But more and more, what's been recognized over time is that there's a wide spectrum of etiologies. Everybody's heard of Prince-Mental's angina, was described back in the 1950s as epicardial vasospasm, which results in transient ST elevation. And that's pretty well known, but it's very uncommon. What we've come to understand now is that vasospasm is more of a class of different diseases that can occur at the epicardial or microvascular level, and so can present with more subtle changes. And there's some diagnostic ways to evaluate this in the cath lab, which previously it's a really difficult diagnosis to make because you need to be able to capture these ST changes during episodes of pain. And then there's the microvascular dysfunction, or ANOCA. This is more recently come to light as we've been finding patients both in the stable state and the acute state who come in with syndromes and have no obstructive disease. And these mechanisms in the microvascular can be structural or functional, where they're permanent changes to the arterioles, or they can be transient, as we discussed. So here we have the macro to the microcirculation. And just to remind everybody that the epicardial arteries play a very small contribution to the overall regulation of blood flow. Here you see only about 5%. Therefore, if somebody has abnormal myocardial metabolism or ischemia during exercise, there is a large chance that some of this could be due to dysfunction of some of these smaller vessels. And, you know, over the last 20 years, there have been development of different tools to be able to differentiate abnormalities in the macrocirculation versus the microcirculation. And you see here the coronary tree. And if we want to look at overall flow in the heart, we can do this by coronary flow reserve, which can be measured non-invasively or invasively. We'll talk about that. Or you can isolate the effects of the epicardial artery by doing what's called a fractional flow reserve or a non-hyperemic pressure ratio. And now, more recently, there are commercially available catheters that will allow you to look solely at the microvasculature, in particular, one called Index of Microcirculatory Resistance, which has a dichotomous cutoff for normal and abnormal, similar to FFR, similar to NHPR, similar to CFR. There are well-defined and validated cutoffs that we can use to again, phenotype a patient and what is causing their anginal symptoms. So now I'm going to move to the 3 cases. And as you'll see, we can see how these patients were worked up and treated. This was a 61-year-old woman who had some risk factors. She'd been having several years of chest pain. I think over 5 years, she'd probably seen 1 or 2 cardiologists before she was referred to my practice. She had typical jaw and arm pain with exertion relieved with rest. It was reproducible. It came on after about 10 minutes of exercise, worse with more strenuous exercise, may have worsened over time, but she's been living with this. Many individuals told her they didn't know what it was or it was in her heart. After she'd had some workups in the past, she was on some medical therapy with a beta blocker and a statin, nitro as needed, which would help, but she often didn't need it. She had grade 1 hypertension, on meds, was normal body weight, normal EKG. The second case is a 56-year-old smoker, had 6 months of chest pain that occurred daily to weekly, mid-sternal, no radiation. It was aggravated by exertion, but also occurred at rest in the late evenings, was also relatively brief. He was also placed on metoprolol and really looked fine from a vital sign perspective and had a normal EKG. And then the last patient was a 59-year-old who had a very strong family history of premature coronary disease, hypertension, hyperlipidemia. This person happened to be a physician in our emergency department, and he was an avid biker. He said for about 3 months, he had this like subtle burning in his chest and arms with high intensity biking. He could work through it at lower intensity. He really wasn't even sure if it was there. It just felt like maybe biking in the cold. He was very well controlled on his risk factors, and EKG was normal at rest. So you can see that these cases really demonstrate the subtleties of how chest pain is described, and how even in a group of people who seem to have, fairly cardiac chest pain, it's really hard to understand, are these all the same? And so in the recent chest pain guidelines, they do recommend the preferred terminology: cardiac chest pain, possible cardiac chest pain, and non-cardiac chest pain. So I would place these patients in the category of cardiac, maybe. Again, at the beginning, you might say they're possibly cardiac, but they have enough typical features. Remember, in women, you have to have a broader understanding of what can constitute ischemic symptoms. So again, they can just be a little bit more subtle. And you have to evaluate the risk factors, and then you need to do some sort of risk stratification and understand the testing algorithms. I mean, for cardiologists, most of the time you get to see somebody. Some form of testing is generally indicated if it hasn't already been obtained. And then again, shared decision making. I think it's just important that patients understand the different available testing modalities, and what that means for them in terms of risk of radiation, in terms of the diagnostic capabilities of these tests. So we should just be talking to people about that. So, there is a simple risk stratification that is mainly based on age, sex, and type of symptoms. People have probably seen this graph before, and this is contemporary estimates here recommended. And you can see that just using this simple stratification, we can put our patients in different categories. And so, we had 2 male patients in the 50 to 59-year-old range that had typical symptoms, and we had 1 female patient in the 61-year-old range. And so their pretest probabilities here are all over 15%. And so this just exemplifies how you can put the history into a categorical pretest probability. The other way you can adjust risk stratification nowadays is if you have a calcium score. So a lot of patients now, either for determining if they have an indication for a statin or as part of some types of physicals, end up getting a coronary calcium score. And you can see here that the pretest probability based on age and symptoms can also be stratified by the CAC. So how do we choose the right diagnostic test? So number 1, is the goal of testing to detect or rule out coronary disease, or is it really only for ischemia guided management in somebody with known coronary disease? Do you have prior testing results? And then also there's going to be some degree of test availability and local expertise. We just started our stress PET program in the last 6 months, but we've had a stress CMR program for 2 years, and we have invasive physiology in the cath lab. So we have an array of, and we have coronary CTA, and now with FFR. So again, you may or may not have things like PET or stress CMR available, but you may have more standard stress echo, nuclear testing. But in the recent chest pain guidelines, there's really, again, you stratify the risk, and there's now more of a recommendation in patients who are younger, in whom they don't have a prior diagnosis, or you're trying to diagnose less obstructive disease, that a coronary CTA is favored. Whereas for older individuals, when you're really trying to do ischemia guided strategy, a stress testing is favored. And again, there's no absolute, and often patients end up getting more than one test, which we'll talk about. And then, of course, there are patients in whom maybe you think it's something completely different, an anomalous artery, or maybe you're getting the testing for a specific reason, like looking for microvascular disease. So all these things would be taken into consideration. So what happened with these patients? Well, that first case, the 61-year-old woman, before she came to see me, she'd had a nuclear stress test about 5 years ago, which was normal. And then she had a coronary angiogram to follow that because of the typical symptoms, and that was reported as normal. And then a couple of years later, when her symptoms persisted, she had a stress echocardiogram, which showed some non-diagnostic ST depressions, but was not considered a positive test. Again, she never carried on her chart a diagnosis of stable angina or microvascular disease, but she certainly was being treated for these risk factors for it. Case 2 had a stress echo, who had no ischemia, had a coronary angiogram with non-obstructive disease. Case 3 had a stress echo and went to a very high workload, no evidence of ischemia, non-diagnostic ST depression, and frequent PACs and PVCs. Based on that, and again, understanding the typical nature of his symptoms, we followed this up with a CT FFR, which actually showed multi-vessel, triple vessel disease with short CTO and the RCA. So again, some of these tests can be a bit misleading. When you have a very fit patient who you send for a stress echo, you might really underappreciate the degree of ischemia. They're very well conditioned. They tend to immediately drop their heart rate when they get off the treadmill. And again, you can see in this case 3 how falsely reassuring that test may have been. However, again, with the ectopy, the good story, CT-FFR was performed. So we have a good sense now of maybe what these patients have, but again, we need to give them a formal diagnosis. Secondary testing, this is just to point out that the guidelines, chest pain guidelines do recognize that it is very common for patients to require more than one test to work up persistent symptoms or negative or inconclusive imaging or exercise tests. And this just shows you the range of testing. If you have stress testing, it can be followed with a coronary CT or a cardiac cath, and sometimes vice versa if you need to get ischemia information. So that's just something you can find in the guidelines as well. Just to show you, I went back for the first patient and pulled the coronary angiogram, and she had, coronary angiography in multiple views. And here I agree, it looks quite good. I mean, maybe one could argue there is some mild luminal irregularities. Certainly, if you put an IVUS in there, you'd probably find some very small plaque, but certainly this is minimal angiographic coronary disease. Case 2, went back and pulled the angiogram, and you see that there is quite diffuse atherosclerosis. You've got periods of narrowing followed by some maybe more normal versus aneurysmal segments. And, overall, this patient was bradycardic, so the flow looks slow, but, also you wonder if maybe there is microvascular disease or another process going on here. So what about these first 2 patients? We already know the third patient has obstructive disease, so we're pretty comfortable and we can discuss what to do and we can see what happened with that patient. But what about these other patients? I think you'll find this is a common occurrence that, maybe 30 to 40% of patients sent to you in the lab may have non-obstructive disease. It's really more common in women than men, and a large proportion have actual ischemia as the cause of their symptoms. It's not that they're non-cardiac, they're just other forms of ischemia. This can be the coronary microvascular dysfunction, vasospastic angina, and this can be in the presence or absence of actual coronary plaques or non-obstructive disease. We know these patients don't do as well as patients who have, no cardiac symptoms or somebody who doesn't have these dysfunctions, because they can have, cardiac events, they can have hospitalizations, there's a lot of healthcare expenditure, they may have an impaired quality of life. So that's why it's important to just get things documented for them and persist in the treatment. So what about the criteria for microvascular angina? Again, you want to have symptoms of myocardial ischemia. Certainly our patient had that effort or rest angina or exertional dyspnea as an anginal equivalent. You need to exclude obstructive CAD. You can either do that by a CTA or an invasive coronary angiography. If there is any mild to moderate plaque, you should exclude obstructive disease with physiology. That could again be done by CT-FFR, or if you need to, invasive FFR or a resting gradient. Then you need to have objective evidence of myocardial ischemia. So many patients will have abnormal coronary blood flow demonstrated on a functional test, like a PET with myocardial blood flow assessment, or again, on some other form of stress testing. We, again, CMR is also available. And then you can invasively look for signs of impaired coronary flow reserve. And again, not everybody has every diagnosis, but in general, you need 1, 2, and 4 to make the diagnosis, or 1, 2, and 3, because you really have to demonstrate all aspects of this. And then for vasospastic angina, you need nitrate responsive angina. And there are certain things that are common, like diurnal variation, like that second patient having it in the morning early or late at night, can precipitate it with hyperventilation. Calcium blockers should suppress the episodes. Beta blockers can actually make them worse. The EKG changes, as we discussed, don't always have to be ST elevation. It can be ST depression. And when you're provoking this in the cath lab with acetylcholine, you really need to see severe vasoconstriction above 90% in the presence of the EKG changes and the symptoms. So if you induce spasm and the patient is sitting there feeling absolutely fine, you cannot diagnose vasospastic angina. So that's sort of the composite of the 2 diagnostic tests. And now a nice addition to the chest pain guidelines is that they do address patients with suspected ANOCA, and that allows for use of different testing again. So these are all class 2. We don't have any class 1, but in patients with these persistent syndromes, you can consider invasive coronary function testing to improve diagnosis and enhance risk stratification. So again, I don't think, I would say that many cath labs are now starting to understand the need to offer this type of testing and starting to add these programs, but they're really still not
Hey, do you know
widely available. Okay, so here we go back to patient 1 who we had a very high suspicion had microvascular angina. I didn't feel we needed to bring her into a cath lab to do invasive physiology because her diagnosis was fairly clear, and we just wanted to demonstrate she had ischemia. So in this patient, we got a stress CMR, and I'll just let this run here. And being an invasive interventional cardiologist, can't really tell you exactly what I'm looking at, but my non-invasive colleagues are sure that she has diffuse subendocardial ischemia. You see here on the stress images, she had extensive reversible stress-induced defects in the basal and mid-septum, basal inferior and lateral segments, apical septum, apical inferior segments, findings suggestive of microvascular dysfunction. She had no evidence of scar or fibrosis. So this was pretty diagnostic in her case. All right, in case 2, about a year had gone by since the prior coronary angiogram. He was still smoking. We decided to bring him back to the cath lab to do physiology because of the, diffuse nature of the coronary disease. And again, it looks angiographically about the same. And you see here that after acetylcholine, there was high-grade focal stenosis. The patient did have chest pain, did have ST depression. So this is pretty diagnostic of spasm. After nitro, look at how good the artery looks, even compared to baseline before any vasodilators. So this was important information for this patient. And then we finish up by using a wire. This happens to be a pressure wire X. There are 2 different systems, a Doppler based and a thermodilution based commercially available systems. And here you can see that just with maybe 10-15 minutes and a few measurements, you can get the fractional flow reserve here, which is normal at 0.9 or non-ischemic. You have a resting ratio. You have here, this patient has a very normal coronary flow reserve. And we know that because the resting flow is slow. And then with vasodilators, it got brisk. But they do have a high IMR. So they do have microvascular dysfunction as well. And again, whether that is a mechanism is vasospastic or structural, we don't know, but they do have some microvascular dysfunction as well. So again, when we talk about the management, we're really left with how we manage obstructive disease, which is a little bit disappointing because all the patients don't respond the same way. I would say, however, in patients with vasospastic angina, we know that calcium channel blockers are certainly the best first-line therapy. And some of these, this is a European statement I was involved in, so some of these drugs we don't even use here in the United States. But again, I would refer all these patients to cardiac rehab. They often just need a lot of, once they know the diagnosis, they can work towards, modifying their risk factors, whether it be obesity, smoking, hypertension, et cetera. We know from the CORE-MICA trial, this is kind of a small proof of principle trial, just to test whether doing interventional diagnostic procedures, like telling patients what their angina is due to, can change their outcomes, just the outcomes of quality of life. So this was a small randomized trial of ANOCA patients where they had just regular angiography versus full physiology. So they could be diagnosed, they could have a strict diagnosis and then get treated. And what you saw over 12 months is that the patients who had a better understanding of the etiology of their symptoms really did much better in terms of their angina scores and quality of life. There was no difference in MACE because it's a very small trial. These patients did very well over the short term, but it just goes to show that if you can really target the diagnosis and therapy, the patients will feel better and do better. Unfortunately, we don't have all the answers. This was a small randomized study presented at the American College of Cardiology. I think this was back in 2022, so not this year, but last year, where they took patients that had either vasospasm or CMD, and they randomized them to diltiazem or placebo, and then they repeated testing. And really what they did find was less spasm and less epicardial spasm, but really that was the only thing they could show. So again, it was a really small trial, but it just really, again, these patients have variable phenotypes. Some have all of one, some have a combination. And so again, maybe a one size fits all doesn't work, and it makes it a little more difficult to study. Just so you can know what's on the horizon, there are several large funded trials going on in ANOCA right now. Some of them are looking at just standard therapies like diagnostic therapies like CTA. Some of them are looking at regular guideline directed therapy like statins and ACE and ARBs. And some of them are more novel, like this one looking at an endothelin A receptor antagonist to treat the microvascular angina, this trial prize. So I think there's some exciting things on the horizon, and the more we can diagnose patients, then the more recognition there'll be, and we can get these patients into trials. So the conclusion for these two cases, the first case was diagnosed with microvascular angina, was placed on her chart in her problem list, and she was referred to cardiac rehab. She was continued on a statin. She was added on an ARB. She was changed to nebivolol, which is a beta blocker that has a ability to help nitric oxide release and vasodilation. And she had a marked reduction in her angina frequency. I see her once a year. She does quite well. She's not had any hospital visits or any further testing performed. In case 2, he was diagnosed with non-obstructive disease and vasospasm. Really, the focus was on smoking cessation because that was probably what was triggering both of these problems. Statin was started, a beta blocker changed to a calcium channel blocker, and he also did better, rarely needed nitroglycerin, and again, working on the smoking cessation. So now let's move and go back to what we are really comfortable with, which is what are the therapies for angina from obstructive disease. And again, I think in terms of anti-anginal therapies, beta blockers are very effective and they're generally first-line therapy. But there are some side effects that patients don't tolerate, which we can talk about. But you have the calcium blockers, nitrates, and then ranolazine. And then there's revascularization by whatever mode is appropriate for the patient's anatomy. I was a part of this patient level meta-analysis representing the Berry 2D trial. This is Dr. Sturgiopoulos. She was a fellow with me actually at Yale many years ago, over 20 years ago. This is published now 10 years ago, and we can talk about what's changed since then. But really, even in randomized trials, we found it's really hard to distinguish a difference in outcomes in patients who are treated with an interventional PCI strategy versus optimal medical therapy. Certainly things like death, MI, really didn't change. And here we even didn't see a benefit in angina in this particular trial. There may be complexities to this, and these are pretty old studies. If you look at more recent meta-analysis, here early and then late over different numbers of years, well out to over 5 years, what consistently emerges is that there is a reduction in angina with a revascularization strategy, which makes a lot of sense. But again, even in these very large analysis here, over 7,000 patients, really couldn't see any difference in hard endpoints. So again, as an interventionalist, it's disappointing, and I always think there's got to be some benefits we're not capturing, but certainly angina relief is a main reason we bring people to the cath lab nowadays. We know as well that ischemia burden predicts outcome. So, these are just old studies here from, this is from a large nuclear lab. It showed if you have over 10% ischemic burden and you are continued on medical therapy, you don't do very well. This is not randomized, this is just observational. They took, like 10,000 patients from their stress nuclear lab. They followed them prospectively, and, and this is what they saw. So a decrease, better outcomes, but again, not randomized. And this is the nuclear sub-study of the COURAGE trial. And in this study, they did scans before and after randomization to medical therapy or PCI revascularization in patients with stable disease. And what they found is that if you could reduce ischemia, you had better outcomes. And more patients that had PCI had a reduction in ischemia, but even patients that had a reduction of ischemia with medical therapy also had better outcomes. So again, I think the onus is on us to assure we can minimize ischemia, whether that's with medical therapy or revascularization. They are both options. But I think we have to be a little bit leery about finding a large burden of ischemia and then not documenting that we are doing something to relieve ischemia. Also by CTA, now that CTA is being done more commonly than stress testing, you might say, how prognostic is that? And it's exactly the same. The more vessels involved, the worse you're going to do, and the lower your risk is going to be if you have revascularization. So here, this is just a, here, 15,000 patients who underwent a CTA who didn't have known disease. High risk anatomy was, again, here, if you got revascularization, you had a much lower mortality. Yet we can't prove this with a randomized trial, but every single observational study shows you just don't really want to leave people with large ischemia. At least we can take that message home. So we all know that recently the long-awaited ischemia trial was published, and this was the trial design. Interestingly, patients had blinded coronary CTA, so anybody with clear-cut surgical disease, left main disease, was taken out of the trial. That's not necessarily the way we practice, but again, in today's day and age where maybe the first test is a CTA, this could be, information that the physician can use to decide on whether initial medical therapy is reasonable as compared to referring right to cath. And as you know, disappointingly, that out to 5 years, in patients who were deemed to have moderate to large ischemia, there was no difference in an initial strategy of guideline-directed medical therapy or an invasive approach, which could be PCI or CABG. And in this trial, about 75% of patients that were revascularized had PCI, and about 25 had CABG, 25%. And you can see there's always an early upfront hazard to revascularization, which is quite small. And then there is some benefit following that, mostly in the rates of spontaneous myocardial infarction here. But again, overall, if you look at this, they are disappointingly similar. When you look at, so this trial, ischemia was supposed to only enroll moderate to large ischemia. However, because of the array of stress testing that was allowed to demonstrate ischemia, including things like ETT, it ended up that there were patients who did not have large ischemia. They only had very minimal ischemia. So again, there are patients with mild ischemia, and also by angiography, non-invasive or invasive, they had very mild disease, like one vessel disease. And you could see that the ischemic burden here had no relationship to outcome at all. However, the anatomic burden seemed to correlate more. So again, ischemia itself did not identify a subgroup with a treatment benefit for intervention. But in the most severe group, which was about 700 patients, the 4-year rate of cardiovascular death or MI was lower with intervention. So again, and these is a retrospective look at this ischemia trial. So, how low can mortality go? Like, how are we doing better? If you look at the COURAGE study, which was published in 2007, and you look at the ischemia published in 2022, and you see like mortality here at 5 years is 7%. Mortality here at 5 years is 9%. So again, ischemia was a much higher risk population than COURAGE, but it's kind of disappointing that, again, in these patients, probably the most likely cause of death is cardiovascular. So I think that just brings up that aside from the standard guideline medical therapy, it's really important that we are pressing patients to either get on a statin or a PCSK9, get them on, icosapent ethyl if they have an indication, get them on SGLT2s if they have an indication, get them on whatever therapies they need to reduce their risk factors and really work with people on that. This is from ischemia trial. There was a very well-designed prospective quality of life angina sub-study. And basically what we learned from that is that if patients had weekly angina, the number needed to treat was only 3 to reduce their angina burden. But if they didn't have any angina at baseline, then they're not going to feel any different later. So again, I think in terms of who are the individuals in whom you can really show a clear-cut benefit in angina frequency, it's those patients who are having at least weekly angina. So at least once a week, they are suffering from some ischemic symptoms, whether or not they're using nitro or just reporting them. And again, patients aren't always that great at remembering how often. So I often really ask people to write it down or keep a diary or keep a count on their nitro use, because sometimes people that get used to it, it's just in the background and they're not even monitoring. One thing I found very interesting about the ischemia trial, having an interest in the medications, is that you can see that over the 5 years of the trial, beta blocker use was very high. Calcium channel blocker use here is about 30% and was the same in both arms. Other antianginals, so patients that did not undergo immediate revascularization did require a titration of antianginals to get their angina under control. And so probably were started on nitrates and or ranolazine. But over time, you can see that some of that use even dropped off. Invasive, it's nice to see that there were some patients that were potentially de-escalated off antianginal therapy. DAP, of course, is a necessary part of revascularization, at least PCI revascularization. But again, so these patients have a high burden of meds that they must take for potentially lifelong. And there's a downside to that. So far there's been no mortality benefit that's been attributed to these, to any specific agent. Now, we know if we can reduce ischemia, we might reduce mortality. So I'm not saying that they don't do anything. But again, we have to just say that some patients, just telling them that, you know, staying on 3 antianginals for the next 20 years is the best way to manage their angina, when there is other effective strategies. So I think it's important to listen to the patient about, you know, again, some patients may prefer daily medication to avoid anything invasive or risky, and other patients may have exactly the opposite feeling, where they are very poor with compliance. They just have a difficult time. They don't feel well on meds, and they don't have an endpoint horizon, and they really want something more interventional or mechanical that can just give them a boost and get them off some of these pills and recover. So we have looked at beta blockers and cardiovascular outcomes in stable ischemic heart disease. We looked at it in a large population in the NCDR here, over 750,000 patients. And they're very commonly used, but we found no benefit on mortality in elective PCI at 30 days or 3 years. Other investigators did similar analyses from large registries here, the REACH registry, 21,000 patients. And again, at 44 months, beta blockers were not associated with lower rate of events. And again, we don't have any randomized trials. Here, this is just the publication, and you see that beta blocker use went up over time. It went up over time independent of the age of the patient, the gender of the patient. And here's just the relative risks, and you see that we didn't find any benefit. If anything, patients that were on beta blocker at the time of their PCI had a higher risk of presenting with heart failure over time. That doesn't mean the beta blockers caused heart failure, of course. Like, maybe we didn't capture some diastolic heart failure in every patient at the beginning of the study, but certainly no benefit we saw here. If you look at the guideline recommendations for beta blocker use, it's actually a class 3 to tell, you know, I don't know why they put it a class 3, but they basically say that there's really a lack of evidence that chronic beta blocker use can reduce cardiovascular events after revascularization. So again, I think that's it's kind of like a difficult thing to digest. Beta blockers obviously have a lot of benefits, but I think it's just to remind us that if somebody's ischemia has been relieved mechanically with a PCI or CABG, you can and you probably should just take them off their beta blocker unless they have another indication for that medication. So when do you do revascularization? Well, often it's just to improve symptoms. There are very few revascularization procedures that can improve mortality. And recently in the REVASC guidelines, CABG was for multivessel disease was even downgraded from class 1 to class 2 for survival. And I would say also just to allow discontinuation of antianginal therapy. So here's the third patient who was the avid biker physician, and here's the CTFFR. So you know, mild calcification, non-obstructive disease in the LAD, and circumflex here you see, and severe disease here in the right, which they called a focal CTO, but there's probably a microchannel there, and you know, healthy vessel on either side. So after discussing with him what the options were, he really felt a PCI was going to be necessary, because we sort of had maxed him out on meds. His blood pressure was below 100 and he was still getting angina trying to bike, and he certainly was not going to give up intense exercising. So we took him to the cath lab. You see here the angiogram pretty well matches the CT, and he got intravascular lithoplasty and IVUS guided stenting with a nice large stent. And then, you know, he recovered for a few weeks. He did, then went on his way here. He sent me this picture after he'd biked like 150 miles, you know, between New York and Philly. And really, we took him off his beta blocker. He was on an ACE, he was on DAPT, he was on both the atorvastatin and icosapent ethyl. He did cardiac rehab. He went to the Dean Ornish cardiac rehab program, and he continues to do excellent. And then, you know, again, he's not had any further events. So we have a research hypothesis that we are able to de-escalate these medications, particularly beta blockers or other types of medications without other indication like nitrates, and that we wouldn't be harming patients by doing so. So we're in the midst of doing these landscape analysis right now. We have analysis going on with the Cath-PCI registry that is looking at linking it to Medicare Part D prescription data, and we are looking at what antianginals the patients are on in the 3 months prior to coming to the cath lab and the 6 months after the cath lab, and in patients who get PCI, and just trying to see what the landscape is, because I suspect that we are in a habit of over-medicating patients, where I think in some other countries it is very routine to stop angina medicines at the time of PCI. And here you see we have a nice population of 3 million people we're working with, and after excluding patients who have certain indications for medications, we still have a nice group. And again, we have some initial data on this, and we will get back to you on the findings. And we're also looking at this in our own institution in our cardiac rehab program, and hoping to do a prospective randomized trial on this soon. So angina therapy is an alternative to PCI. Orbita-2 was just presented and published this year in New England Journal of Medicine. As you know, maybe you remember, Orbita-1 was a disappointing trial, which was like a placebo-controlled PCI trial, which failed to show a change in exercise time or outcomes in patients who were randomized to PCI. Well, in Orbita-2 was an interesting trial design. It was blinded. Patients didn't know if they were undergoing revascularization or not, but in this trial, they actually discontinued angina medication. They made sure people were having angina, and then they did the PCI. And you can see that at 12 weeks, if you had PCI, your angina score was markedly improved. So again, it just sort of shows you, it's like a, interesting, it's in the New England Journal of Medicine, but yes, if somebody has angina and you take them off their medication and you give them a PCI, they're going to have less angina. But I think the point was that in Orbita-1, the patients were on such aggressive anti-anginal therapy that it might have affected their exercise tolerance. And in that trial, when I talked to the principal investigator, she said that when she asked the patients, like, you guys are getting me in trouble, why don't you feel better after PCI? That a lot of the patients were like, well, wait a minute, doc, we don't know if we have a stent or not, so we don't really want to push ourselves on the treadmill when we get that follow-up stress test. So even in a placebo-controlled trial, there is something biasing the patient, and they're not behaving normally. So I thought that was quite interesting. So key takeaways here. It's really important to have an approach for patients with stable cardiac chest pain. Selection of the testing modalities now with CTA versus imaging, just thinking about how to use those, and then what to do in patients in whom you don't find obstructive disease, but you're pretty convinced to have a cardiac etiology of their chest pain. Management of atherosclerosis, both macro and micro beds, and choosing patients for revascularization, and again, consider taking them off medications when they're not needed. So I'll just put up this last slide for everybody, and thank you for your time.
Thank you so much, Dr. Abbott, for the great talk. And now we can take questions. If anybody have a question, they can speak up, or I can just type it in the chat function, and we'll read it to Dr. Abbott. I think I can start with the chat. I think Mohammed Beer, he's one of our interventional fellows. So thank you for the excellent talk. Have the results of Orbita-2 trial changed your practice?
No, but I'm happy that that it was published. I mean, I don't think Orbita-1 made me less likely to offer someone with stable angina a PCI, because again, it was a very small study. Patients again had very small ischemic burden in that trial, so maybe documenting a difference was difficult. I just think it's a interesting study design that doesn't mimic clinical practice, because in general you wouldn't be de-escalating anti-anginals prior to a PCI, but it does lend to my tendency to discontinue meds post PCI. So if anything, it sort of supported what I generally do, which is to reassess all medications at the time of a cath, whether it's a diagnostic cath or an intervention. As an interventionalist, it's really important that you're not just, like doing a chest x-ray or something, that you're a physician. And if somebody comes with non-obstructive disease, you have to make sure they're on therapy for non-obstructive disease, or you need to recommend further testing if you think they need microvascular testing. And same thing, like, I think it's just like think of it as everybody should be contributing to the cardiovascular health. So it's sort of, you don't want to just place a stent and not be talking to the referring doctor about optimizing all the medication.
Thank you. So I have a question.
Yeah.
Go ahead. Yeah.
Dawn, great job. Thank you. Question I have is, and this really bothers me. You just gave 45 minutes of great information about how to go through all these diagnostic steps. And yet the take-home message that most people have, I fear, in just general practice, have taken from the ischemia trial is, you don't need intervention. You can do just as well with medical therapy. And this fact of having to screen patients to exclude severe coronary disease is totally left out. That step is skipped. And I'm worried that a lot of primary care doctors are going to put a patient on a beta blocker, they're going to feel better or have less angina, maybe not feel better, but they're not going to ever get screened for bad coronary disease, and left main people are going to be shortchanged. So how do we educate? What do we do about this?
Yeah, and it's not only primary care physicians, it's also consultative cardiologists. And I've had cardiologists in our own practice not know what to do. So this just happened. One of my partners who's been practicing 20 years, she's quite capable. She's an excellent, multimodality imager and cardiovascular consultant. She, again, had a patient who had an abnormal stress test. She sent them for put them on antianginals, still had angina, sent them for a CT, has triple vessel disease. And she said, and put them on more meds. And then she said, I just don't know what to do with this patient. Should I refer them for a cath or not? And I was like floored, right? Like it's confusing people. They don't know what to do. So, and I was like, well, just looking at that, it looks like he has surgical anatomy. I think at a minimum, we should confirm that the CT is correct, see if he has surgical anatomy, and offer him surgery, right? Because again, even though these trials say you can walk around with all this ischemic burden, like ischemia trial didn't repeat the ischemia testing. So we don't really know which patients didn't do well. And remember, in ischemia, it's an initial strategy of guideline-directed medical therapy. So within a few years, about 20% of patients in the medical management arm undergo revascularization. It's just they don't undergo it right at the beginning of the trial. It's not like it's permanently prohibitive. So I think, again, we have to say that, yes, initial management, make sure you've excluded at least surgical anatomy, and then you can decide from there. But I think excluding the surgical anatomy is an important part, because ischemia was certainly underpowered to detect if, PCI versus CABG was better. It wasn't a trial designed to do that. Same with Berry 2D. If you remember Berry 2D, that's all diabetics, and they had this diabetes stratum with diabetes management. They had a revascularization stratum, and it could be PCI or CABG. And there was a trend towards better outcomes among those who underwent CABG, but it wasn't randomized, right? So it's not a conclusive trial, but it did show that patients with the highest burden of disease did better with revascularization. So again, I think if you do find someone with single vessel disease, and you can medically manage them because you have a CT that shows single vessel disease, great. But if you have large ischemia and a symptomatic patient, you might as well just send them to the cath lab, or you could get a CT, but then you're just sitting there. And in the past, the interventionalists had to make a decision. Now what's happening is these CTs are getting done, and they're going back to a wider array of people with varying levels of understanding of the data that are trying to make a decision. And so I think the key is to, if you don't, again, to involve this multidisciplinary group of people. Like if you get a CT back and it's showing multivessel disease, maybe you just need a surgical consult and maybe the surgeon will request an angiogram. But I think just putting them on meds and not doing anything is a potential liability for you and the patient, I would say.
Thank you. I think there's a question from Dr. Michael Contus. Excellent talk. Although the trials may be disappointing from an interventional point of view, at least from the patient perspective, is that it gives the patient options, which is helpful for the ones who are reluctant to have cath. But I still go for cath for those who want to know what's going on. I think it's more of a comment.
Yeah, no, and I completely agree. And honestly, having the availability of a CT is, I think, really assisted us in managing patients, because we can get the anatomic data without the risk. So again, I think over time, there should be less people that come to the lab for diagnostic procedures, right? The cath lab maybe will become a place for invasive diagnostics and interventions. You know, it should be uncommon that somebody makes it to the cath lab and you don't know if they have obstructive disease or not. And I'm talking about stable patients. Of course, with acute coronary syndromes, you're going to go right to the cath lab. But for stable patients, I'm finding more and more they're coming to the lab more and more with a diagnosis or a question, a specific question. And again, so if you have pre-test, you know, if you have a nuclear test and you then get the anatomic information on the table, you can make decisions. Or again, if you know ahead of time that they are likely to have non-obstructive disease, you could plan for physiologic testing.
So I think Pierre has a second question. So do you recommend routine coronary provocative testing in patients with ANOCA or MINOCA?
So no, not routine testing. And we often, unless somebody is coming to the lab with no non-obstructive disease. So if someone's had a CT and you have a high suspicion and the reason they're coming, we would consent them and do the testing. You have to have a high index of clinical suspicion to offer vasospastic angina testing. So we don't do that in every patient. That would be a particular patient. And often we just see if their symptoms respond to calcium blockers. But the microvascular phenotyping is exceedingly low risk, very easy. So you can just use a commercially available wire, something like a pressure wire X. Particularly, you can, if you need to check the FFR, but then you can do a CFR and an IMR, you know, in like 15 minutes. So, but again, we often don't do it at the time of the initial, if they have no prior anatomic definition of disease. But now when patients are coming, we can set them up for that. So again, that's what's helpful. But it does take somebody in your lab who's really interested. You know, not every interventionalist wants to do physiology. So if you can identify someone who's interested, then it could be a day where you just have the physiology. And we have a heart center now, like a women's heart center. And that way you have a group of individuals who are assisting in the management of those patients. So they're not spread out all over your practice, because they're really, when it comes down to it, not that common, right? Like I have a handful maybe of clear-cut microvascular angina patients or vasospasm patients, right? I could probably count them on 10 fingers, and I've been practicing 20 years. So it's really nice to centralize the care of those patients if you can. And so I think that's happening more and more.
Okay, thank you, Dr. Abbott. I don't see any more questions in the chat. I think, you know, we can probably conclude 8:27. Thank you so much, Dr. Abbott, for the talk. And if I get any more questions, or Shannon, they probably can email to you. Thank you so much.
All right. Nice being here this morning.
Thank you, Don.
Okay. Bye, guys.